Hello, good evening, good afternoon, good morning, wherever you are. I'm Dr. Philip McMillan. I've been speaking about COVID-19 since early 2020, and I've had the pleasure of speaking with experts across the world. And today is no different. Now, it's not my usual Saturday time because I think we had to tie it all together, but I have three great guests who are going to be focused on the question about microclots. And if anyone remembers my recent presentation with the embalmer's clots, one of the types of clots that they noticed increasing by in 25% of the corpses was that of what they call coffee ground or a grainy clots, which were different. And these may fit closest to what our experts are going to be talking about. Myself and Shankara are going to be listening to the presentation. We'll be adding balance and context and trying to add questions and make sure we clarify the points as we go along. So, without further ado, I'd like to introduce the guests. I'll just add them in and I'll ask everybody to unmute their mics. And we'll start probably with Robin, then Joachim, and then Shankara as the introductions. You want to go ahead and give a quick introduction, Robin?
Sure. Hi, you hear me?
Yeah.
Okay. Hi, everyone. I'm Dr. Robin Ruse. I'm a double board certified gastroenterologist, internal medicine physician. I've been practicing I practiced conventional medicine for about 17 years, and I've been practicing functional integrated medicine for the last 4 years. And I've got sucked into the world of COVID and long COVID since the beginning of 2020. And I've been working with amazing scientists, physicians, and researchers all over the globe since then. And the people in my company right now are some of the most amazing people and great mentors. And I'm happy to be here.
Wonderful. Thank you, Joachim. And thank you, Robin. And Joachim?
Yes, hello. My name is Joachim Gerlach. I'm from Germany, and I'm head of research and development at Vedicinals, and in very close partnership and collaboration, of course, with Dr. Robin Rose, trying to help patients and to develop solutions and protocols that can get the people better.
Wonderful. And Shankara?
Hi, Philip. Hi, everyone. Can you hear me?
Oh, yes, we can.
Okay. My name is Shankara Chetty. I'm a general practitioner from South Africa and a natural science biologist. I've been a frontline doctor treating COVID from the start of the pandemic and trying to understand the pathophysiology around the disease. That's morphed into treating long COVID and, of course, trying to understand the vaccine injuries. And all the people in the group are bringing a lot of new advances, which I'm eager to try on my patients and make sure they get well.
Excellent, excellent, excellent. Good. So let's get started with an important short video. And before I show it, Joachim, I want you to explain what this video is about so that people watching will understand what they're seeing.
Yes, that video came out like 1.5 years ago. It was a study from the Helmholtz Institute in Munich, in Germany, and they did experiments on mice with fluorescent spike protein, which they injected, and also the second part of their study was to look at deceased people and do pathological histopathology and look at the brains in particular and stain for spike presence. And so this video is quite sobering, and I think it's a good, let's say, intro into our topic today of how to detox spike protein that is stuck in the body, and also by doing that, eliminating microclots. So if we want to look at that video, I can also maybe comment while it's running.
Wonderful. So let me play the video now.
So these are mice that were injected, and you can see the kidney, all organs are very, very strongly affected by spike protein presence in the cells. In the intestines, the same, in the intestinal linings, in the ovaries, in the testes. Everywhere you see this fluorescent light coming up, that is detection of spike protein. And the worst part, of course, is in the skull bone marrow, and in the meninges, and so to speak, on the periphery of our brain, that is all spiked up. And that is, of course, there for a very long time. I just had another paper yesterday, up to 600 days, you can detect either live virins and/or spike protein or spike protein fragments in the human organism. It doesn't go away by itself. And so this paper is that was really a wake-up call, because many people think that spike protein is just floating around in the body, in the blood, but it is actually more than 90% or even more than that stuck in the cells, and especially in this delicate part of the organism where we speak about during my presentation. You don't want to have that, and you want to get it out.
Excellent. So just to make sure I got it right, the video was of mice that were vaccinated with which vaccine? Do you know?
It was not a vaccine. They took recombinant spike protein, like we did also in our own lab, and they put it in fluorescent dye so that it will show up on a scanner. That's one.
And so was it injected intravascularly, or was it injected?
Yeah, you can. Yeah, it was injected intravenously, and we injected it by all means into the tail of animals. We injected it into the subcutaneously, how you call that, in the under the skin, and also intravenously, and it equally distributes through the whole body. We come to that later. And the second part of that video was actually not mice; these were humans. The skull bone marrow findings and the meninges full of spike is actually findings in pathological examinations of deceased patients, and they found huge amounts of spike protein and neutrophil in activation in the brain periphery. So that is something you don't want to have, because that explains a lot of the microclotting and, of course, of all the neurological symptoms.
Any thoughts, Shankara?
Yeah, Philip, it shows the wide distribution of spike and shows its affinity for all the different tissues that are there. So I think, we got a road ahead in trying to detox it.
And I'm trying to think. So you could have someone who is a detractor looking at this and saying, how is this representative of the general population? Any thoughts, Robin? How accurate is this a representation?
I mean, again, this is animal models that we're looking at in the first case that Joachim said, but if they did look at it both subcutaneously and intravenously, I mean, they didn't do it intramuscularly like we do for, the shots, but that's pretty similar, as far as how it distributes within human beings. And he also showed how in the pathological exams of human beings, post-mortem, the spike protein was still there in the skull meninges and in the skull bone marrow and the meninges. So that's pretty impressive. That means it's widely being distributed after we're exposed to the spike protein in whichever way.
Okay, that's important. Okay, you want to take us through some of the slides of the presentation, and what we'll do, Shankara and myself, is as we see questions, we'll kind of interrupt to make sure we get clarification and try and make sure it makes sense for the listeners. So, who wants to start with this?
I will start the first part of the presentation and then give over to Robin, because we have structured it that way that, first of all, I will be describing what we are facing in the science, in the findings, then describe successful strategies, and Robin will then show what happened in her patients and what is her experience by using these dietary supplements in protocols on her patients and what the outcomes are. So that's how we thought it makes sense. Okay. So we can start with the first slide, and we can go right in there with like what we are facing. So yeah, this is our group here, and just to give you an idea, we work also in the German laboratory with Professor Hans Rausch on the development of all these products, so that we can ensure that they do have the necessary bioavailability and the right composition and synergistic effects. It's mostly emulsions we're working with that are highly bioavailable and penetrating into the organs to do the job that we require them to do. So if you go on the next slide, you see that we test everything in preclinical and in vitro laboratories. At the moment, we are setting up a new laboratory together with Dr. Kevin McKern, the neuroscientist in Japan, to work on hamsters and to look at the spike detox protocol, and as well as the coagulation cascade, and most of all, of course, into the neurological symptoms that these hamsters are developing after injection of both recombinant spike protein and mRNA vaccines. And so that is what we are doing before we even start looking into humans. So that is the usual way we work. On the next slide, you see then what we did in last year in the summer. So we proof of concept. We wanted to see how does spike protein distribute. So this is our own trials, and you can see the animal was, after injecting it into the tail, in that case, after 72 hours, the spike was spread all over into the complete organism. So we can only confirm what the Helmholtz Institute did. It is actually really happening in front of our eyes if we try that.
One question here, Joachim.
Yeah.
As I look at this here, so again, I'm trying to understand. So what was injected was the protein, the
It was
spike
just
protein.
the spike protein, the recombinant spike, and it was mixed with a fluorescent dye so that it would show up on a special scanner, and we can then see the distribution. And we did tests also without we did several tests just with the dye, and just with the spike unmarked, and it didn't show anything. So it was a proof of concept. Can we detect spike distribution in the organism? And it worked well.
Any thoughts, Shankara? Do you think that the fact that they're using spike protein here, because one of the things we're questioning is that a representative replication as to what we're likely to be seeing in terms of vaccines and potential vaccine injury? Any thoughts, Shankara?
I think it is. I think it is, Philip. Yes, we might get variations in the spike itself, but what the animal models are demonstrating is that, irrespective of the route of inoculation, we're getting a wide distribution of it. So I would suspect we're getting distribution through blood, distribution through lymphatics. There's a wide variety of mechanisms at play to distribute the spike that diversely. And of course, the worrying thing is it clearly crosses the blood-brain barrier and gets into the neurologic tissue in the brain. So yeah, it shows clearly that there is a widespread biodistribution and correlation with pathology. It shows that there is some correlation between the human pathologic findings and the animal models. So yeah, we can draw inferences from it.
Okay. All right. Let's move along. Continuing.
Yeah. So, because on the next, let's go to the next slide and then have a closer look. This is the study that we derived the video from. So you can see their findings are clear in humans, in pathological examinations, post-mortem. They find enormous amounts of spike in these areas. Especially, they were looking at the skull, bone marrow, the meninges, and we know also from other studies that the cardiovascular system is full of spike and the endothelial cells, which we come to in a moment. So if you go to the next slide, you see some screenshots from that paper and from the video. You see again, these are areas that are so sensible, and you don't want to have this highly toxic, neurotoxic spike protein in that vicinity to the brain. Plus, you have a very high amount of neutrophils in the same area, and they are triggered by the spike. And when they meet the spike protein, they are going to dissolve it and create something worse and more toxic than the whole spike itself. And these are the 7 epitopes that are embedded in the spike. And once they are liberated, they create this amyloidogenic, prinergic, and thrombogenic fibers. And that is actually like a binary weapon almost. It's really to be avoided at all costs. We go to the next.
Just before we move on there, so just because this is demonstrating an infection, isn't it? What occurs? It could be argued that this is more likely to happen in infection than, for instance, in vaccination. Any thoughts on that, Shankara? Would it be the same?
I don't think so, Philip. I think infection, we have the added complication of a viral infection, which been shown. Virus has been shown in many tissues around the body as well. With vaccination, you'll get the distribution of spike without the viral infection there. I think there's other things that need to be considered with infection itself. If your body is able to overcome it, then you have a very short dose exposure to spike. Whereas with the vaccines, you might not have the virus present, but you got a long exposure to production of spike protein. So the mechanisms might be at play, but I think the way they play out in the different individuals is going to be a little different.
Yeah, I think I was just trying to, again, I'm making sure that I bounce the questions that others would ask, which is that
Um,
they would probably argue that infection in certainly in the post-mortem, may represent a higher risk because we know that this occurs in terms of the accumulation in the skull. But we don't yet have any studies that demonstrates clearly this occurs in vaccination. We are presuming it. I suspect nobody has yet done that kind of research. But it's just
uh,
to make
we get to that. It has been done. Anna Burkhardt has done that in Germany, and there's plenty of publications. It would look, if we want to go in all these details, we would need probably somewhere like 20 hours. But
yes.
so I just took some representative papers here. It's over and over and over been proven now that the spike protein from the vaccine is causing as much damage as the spike protein from infection. We come to that. We have three perpetrators. It's the virus itself. It's the spike that is being shed off the virus when it is in the process of endocytosis. So you'll have a lot of spike also during infection. And then you have the spike protein that is being repeatedly and persistently produced by transfected cells over a very long period of time, as we have learned from our dear colleague, Dr. Carla Bronya. So actually, you have spike everywhere, plus you have virulence everywhere also. That is another thing. We just named this spike detox, but you also have to detox pockets of active replicable virulence in the organism, which also stay there for years sometimes, reportedly. No? But okay, let's get back to the presentation, otherwise it will take too long. Again, here you see what is really worrying is the kidney. The kidney is susceptible to spike damage in a very strong manner because the spike there is causing syncytia. That means when the spike meets the cell membranes, it fuses them together into a cell conglomerate. And these cells become dysfunctional and highly inflammatory. They are secreting cytokines the whole time, and they are not being removed. The spike protein creates its own no-go area, so to speak, in the body where the immune system doesn't touch it, autophagy doesn't happen, and these cells turn into senescent zombie syncytia conglomerates, especially in the kidney. That is why I show this here is because when we start to detox, one of the organs where the detox is taking place is the kidney and the liver. And so we have to protect these organs, especially if we even want to attempt any detox. Let's go to the next slide and we get into the details. Here, that is answering your previous question. So Anna Burkhardt could show in pathological examinations that this is a cut through an artery, and you can see everything that is in that ring, that brown ring. This is spike fluorescent antibodies, and it's completely full. All endothelial cells are full of spike, either on the membrane or in the cytoplasm. And that is, of course, in the whole organism. That will include the brain, will include the micro vessels. And there again, it is another problem because we are seeing the neurological symptoms in the long haulers. And it resembles, if you look at the MRI scans, it resembles something like a vascular dementia because of the impaired blood flow in the brain and the endothelial inflammation. These cells will become dysfunctional when the spike is in there. Now, so if you can imagine your whole endothelium is dysfunctional or a big part of it, then of course they will excrete cytokines. You will have all the mechanisms will be triggered that cause thrombosis and microclotting, and you have endothelial debris being shed off. The glycocalyx is destroyed, and it goes on, and it's a very long list what will happen now in this cascade. So this has to be removed. You cannot leave the spike in these cells by under no circumstances. If we go to the any questions?
Yeah, I do. So this study was done, this was synthetic spike. So this showed
This is vaccine. This is vaccine spike, exactly, to answer the question if the vaccine spike can spread. I mean, it's logical. You inject the lipid nanoparticles with the mRNA and give cells the instruction to transform themselves into spike factories. And they keep going, producing spike ongoing for a very long time. And that spike will then go through the bloodstream. And if you look at the affinity of spike protein, I mean, the spike protein function is to hook up to cells, to bring the virus to the cell. So how can anybody with a 5-sense intelligence even assume that spike protein will stay long in the blood? It will go and do what it's supposed to do. It will fuse with cells. So when you're producing spike in the billions over a long period of time, these spike will spread out through the organism and attach to any kind of cell that they are prone to bind to, like these endothelial cells, for example.
Okay.
That's what's happening. And they stay there for a very long time. That's the problem. They don't go out there by themselves. We have to kick them.
But once that cell becomes transfected with the spike, and the spike is, then that cell then eventually becomes the senescent zombie cell, right? Because it can't survive.
Yes.
Well, one of the questions would be, I could understand if it was the mRNA that got into the cell that then makes the spike. But if the spike itself, which is just a protein, gets into the cell, it shouldn't have the capacity to replicate on
No,
its
it
own.
doesn't replicate.
It doesn't.
It just accumulates.
It's enough one spike protein. If you have one spike protein in a cell, it will turn the internal mechanism all completely upside down.
Right.
Yeah? So anything that could degrade it or kick it out or destroy it is blocked. The spike wants to survive. It's a survival mechanism built into these proteins and into the virus that once it's inside the cell, it doesn't want the cell to degrade it or to get rid of it. It's very simple.
Okay, let's move on.
And so here you see that there are more cells than just the endothelial cells, mostly the pericytes, which are kind of bridging between the endothelium and the space behind the vascular space. And that is like a bridge mechanism from there into the brain, for example, into the parenchyma, where you don't want to have virus and or spike protein. And it will persist there for a long time, just to give you an idea where it all goes.
Just to clarify to people that this kind of setup with the blood-brain barrier is very sophisticated, primarily only occurring in the brain.
Yes.
Okay.
Yeah. We go to the next slide. There you see another big problem that is also in the vascular, in the neurovascular system, and behind it is the astrocytes. And the astrocytes are responsible on both sides of the equation. They are on the endothelial side, they are guardians of the blood-brain barrier. And so when they get hit by spike protein or by virus, the blood-brain barrier is breaking up. So that means all toxins and inflammatory cytokines and whatever can go into the brain. And on the other side of the brain, we have a system, we get to that in a second, it's called the glymphatic system. And that system is responsible for flushing our brain while we sleep and to get rid of toxins that build up. And that system is completely blocked during post-COVID or post-vac conditions. So we shouldn't be surprised that we see the cascade of neurodegenerative disease being accelerated in these patients. Yeah, because you have it's like all your wastewater systems in your house, I block them all, but I keep everything running, the shower and all the sinks. Sooner or later, you'll have an overflow, and that's what happens in the brain because of this, what we see here.
Okay.
Next question here. Yeah, that has been reported here. That we can skip over that quickly. It's the glymphatic system and brain fog. That's a schematic illustration of the glymphatic system between the arteries and the veins and the lymphatic system. So that needs to be restarted. Also, when you want to go and start to detox spike from the brain periphery or from the brain itself, because if you want to get it out there, how can you get it out if your glymphatic system isn't working? That's why it's important for spike detox to understand. Okay. Yeah, but we can go further than here. Yeah, and then if you go one more slide, these are also pathological examinations of brains, and that is what we see then. On the left side, you see a control brain sample, In the second from the left is an Alzheimer brain sample, very strong microgliosis, brain inflammation in aggregates. And then you see on the second from the right is a SARS-CoV-2 infected brain, looks almost as bad as an Alzheimer's brain. And on the right, you see an Alzheimer patient that got infected with SARS-CoV-2, which then turns out to be a complete disaster. Just to give you an idea, what is the consequence of the presence of the spike in the brain periphery. Next slide, please. So we go now to, so I can show you, that's a different presentation. We can do it one day. I call this the pressure cooker. That means the complete brain periphery is blocked up, inflamed, open on one hand and closed on the other, creating like a environment that you don't want to have in your brain. Now, because it is activating everything you don't want to have at the same time. And on the next slide, you see then what happens once the pressure cooker is fully in motion. Then you start to see that is let's say the second phase of neuro-COVID is when you see then the real neurodegenerative severe disease developments. Aggregation of amyloid beta, of alpha-synuclein, Lewy bodies. You have microgliosis, brain inflammation, ferroptosis, and all these mechanisms that you don't want to have. And it's all a result of the presence of the spike causing all that, and of the virus sometimes, of course.
Can I make a point here? Is that one
Absolutely.
of the things that, in terms of dementia, it's been one of my pet topics for many, many years before COVID. And based on what we're seeing, both with infection and the spike protein from any other source, it was already a pandemic. It was already globally doubling numbers every 20 years.
Yep.
At the rate it has gone with the pandemic, we could be seeing doubling maybe even every 5 to 10 years. This is at a scale that I cannot explain how serious it is. And once it starts to be realized, meaning that the damage has been done and people start to have symptoms, it is absolutely too late. And before we move on, any thoughts, Shankara?
No, absolutely, Philip. I'm seeing it in my practice, the neurologic issues that are coming from the vaccine itself. And I don't think people realize it just yet. Like you said, it's going to take a little while for it to show up clinically. And then the statistics are going to show the immensity of what we're actually dealing with. There's a big lag that giving us a false sense of security.
Yeah. Okay.
Let's
All right.
continue, otherwise we'll never finish.
Yes, that's what I said. So jump through because we want to hear some of Robin's experience from a clinical
So
point of view.
I'll go very quick. So this is a video. I took some screenshots of the senescent cell formation, which I mentioned before. Cell conglomerates being built, and these harbor a lot of free spike and or virulence. So these are the areas we want to knock out for sure. That's where most of the spike is hiding. If we go to the next slide, you see also that the immune cells are full of spike and or virus. That's another big problem. How do we get them out? Because your monocytes, macrophages, CD4, T helper cells, and other immune cells of our own immune system are filled with coronavirus and or spike protein. How can they properly function? That's why we do see to some degree now a very strong immunodeficiency in the general population. But another topic. So let's go to the next slide and look at what we are facing. So the task is actually, we have two kinds of cells. One I would call the productive cells. That means they have either mRNA lipid from the vaccine inside and produce spike because of that, and they don't stop. Or you have cells that are still infected with SARS-CoV-2, and they produce new virulence and, of course, also spike protein. And then you have the second type of cells, which are called depot cells. That means these are cells that are just harboring non-productive spike protein, but nonetheless are highly inflammatory, and it doesn't go away. So that is what we have to take care of in our, let's say, protocols. That's what we're facing. That's the task. So let's go to the next slide and have a look how it looks in the vaccine injured people. On the left side, you see a lipid nanoparticle containing mRNA that is transfecting cells, converting them into spike factories, and they are excreting 3 different kinds of products, so to speak. either just spike protein alone, spike protein in extracellular vesicles, or mRNA in extracellular vesicles, which will then go to other cells and do what we don't want them to do. So that is what we are targeting. I don't want to go into much more detail because of the time today. Let's
Oh,
go to
hold
the
on
next
there.
slide.
A
Yeah.
second there, George. I think that is probably my biggest concern,
Yeah.
is that when I look at the long COVID, the long haul picture, I've always worried that what we're dealing with is not necessarily active infection in people 6 months, a year down the line, but long-term ability of cells to produce spike protein on and on and on, with no real way to try and get rid of it. I think that's the big challenge. And when I look at that picture there, that just highlights to me, once some of these cells, especially if it happens in an immune cell that can live a whole lifetime, we have a real problem with getting rid of these lipid nanoparticles, which can then spread to other cells via extracellular vesicles.
Yes, I mean, in principle, everything is doable. We are still lacking some data. We are very far ahead of the curve anyhow globally, but we need now these animal trials with examination of the tissue to see if we can really get rid of every aspect of this ongoing disaster. But yes, you're right, it is a concern. But if you have enough load of spike gotten into your cells, even if you don't have any existing production of spike, it's still bad enough, because the cells that were transfected with the spike, even if it's a deposit cell, will not die. They become immortal in this senescent process. And so it will stay. We have document now, I didn't include in the slides, 650 days of presence of spike protein in senescent cells. No.
650 days.
Yes, sir.
That is just almost 2 years.
Yeah. Now, so if we wait a little bit longer, we find out maybe it's 3 years or 4 years.
Right.
So let's go to the next slide so that we have also some time for Robin to speak.
Yeah.
Let me run you through this. So these are extracellular vesicles containing spike. Another way that especially syncytial formation is syncytial conglomerates are very prone to spit out these exosomes or extracellular vesicles, and they contain, amongst other things, spike protein. And these extracellular vesicles are actually like our own lipid nanoparticles that we produce in our own body. They can fuse with any cell. They don't need any receptor. Makes it very dangerous in that case. They can also harbor good things. We are using them as Trojan horse for our molecules. So it's not only bad. It's just a container that can go through any door. That's all. But we see that a lot. So on the next slide, we want to delve into. So the first thing that can be done is autophagy. Here's a paper looking at especially autophagy being blocked in COVID-19 pathogenesis, and what the molecules we are using can do about it. Because if you want to go the route of autophagy through intermittent fasting and these kind of measures, the virus is prepared for that, and the spike protein. It has blocked successfully most of the autophagy mechanisms, so you want to override them. And this can be done with these molecules. So that's the first way of trying to reduce the number of spike in cells.
And just to be clear, to make sure everybody understands, you are saying that normally what the virus does is blocks these cells from dying.
Yes.
So that they become immortal, infected with either the virus or remnants of the virus, and then continue to produce it. And even fasting, you said, doesn't interfere with that?
Yeah, because it's been blocked. So the mechanisms you trigger through fasting, we have no real data, but the findings of other papers show that these pathways are blocked successfully. And so the only chance we have is to try to push from the outside to restore the functioning of these pathways and get these cells into an autophagy process again so they can degrade some of these proteins.
Okay.
But that is not proven yet. That is a hypothesis, and it seems, but in the overall setting of the patients, it seems to help what we're doing. So this is what I say is just like one of the many ways how you can get rid of spike would be an approach in this direction. But let's go to the parts that we really know they work. Let's go to the next slide, please.
Yeah, next one beyond this one.
Yes, there we go. So if you have cells that are in a senescent state, there is now enough evidence in vivo on SARS-CoV-2 senescent cells that senolytics can really make a big difference, and they break up these cells. And so we have created now senolytic, let's say, compounds that are helping vedicinals, which by itself is a strong senolytic, because quercetin is in there in high amounts through a metabolization process in a very pure form in the serum. So we are helping vedicinals with this other product here and breaking up the cells, be it syncytia and or single cells harboring spike and or virans. And by doing so, we get these cells removed because anyhow they are a very high, they excrete a lot of cytokines, and so you want to remove them anyhow. It's a very common anti-aging method also to take out these senescent cells in elderly to fight the aging process. So that is a very safe and proven thing to do. The only problem is, when we look at it now, if you start to move and mobilize virins or even spike protein, it will then go into the bloodstream or into the lymph stream, and then it is prone to just go to the next cell and destroy that in an instant. So we have to make sure that this is being done in a very, very controlled manner. Everything has to fit: molecular size, bioavailability, the presence in the serum, the half-life, and the ability to chelate. So let's go to the next slide, and I guide you through the whole thing. So these are all SARS-CoV-2 documented senescent and syncytia cells. On the next slide as well, we can later give out this presentation. So it's over and over documented that the spike protein and or the virus is very much present exactly in these cell conglomerates. And on the next slide, you see a very nice paper that was trying to break open SARS-CoV-2 syncytia with some selected senolytics, and it works perfectly. So this we know, and also Robin saw that in the patients, when we start to break up these cells, spike is coming out and virus is coming out, and we can then deal with it. So that's step one of the detox protocol that we think is making the most sense. Now we come to the next part, which is the binders. So I have to make it bigger here. So we have already in Vedicinals and in other products that we're using in this setting, many molecules, but in total it's now 11 or 12 already, that are binding to the spike. And if you use the senolytic and the binders at the same time, you can make sure that you are having enough presence of binders when the cell is broken open and the debris comes out. There are other things to consider as well. It's not only spike that's coming out. There's a lot of other debris, RNA fragments. You have a lot of collagen type 1 from the membranes that can be fueling into the clotting cascade. So there's a large number of other things you want to consider, which would take up too much space today to discuss in detail. On the next slide, you find more examples of the chelators, and these are especially targeting the RBD, but we are not only relying on the RBD, because we're looking at full spike protein, we're looking at the S1 subunit, we're looking at spike in the prefusion state, and also with an accessible RBD. So it's 4 different kinds of spike we want to target. You have to be very sure that you cover that well. Otherwise, you're just going to shift the problem from a completely destroyed cell, shift the problem to healthy cells, and make it even worse. So if we go to the next slide, you see more about the binders. These are all tests of epigallocatechin and other binders we have in our products with their binding affinity to different parts of the spike, including, of course, the RBD. On the next slide, you see another study on the spike binding of many, many molecules And if you look at the fourth from the left side, these are all molecules we are using. They reportedly have the highest binding affinity to spike. And so we are very confident that we do a good job here. And on the next slide, you see also another product we are using. It is a sulfated polysaccharide. And as you know from Dr. Beate Jäger, heparin and heparin sulfate are actually the most prone to bind to spike. And that's why she's using that to wash the blood of patients with their HELP apheresis to get the spike out. We have now included 2 more molecules that are 4 times better at doing that than heparin to bind to the whole spike. That was unheard of. And so we are now really bringing out the big artillery to make sure that we bring out the spike and whatever's out coming out there in a safe manner. Let's go to the next slide, because now we have to also look at different body regions. Okay. Here we see then the next problem. If you maybe miss some spike and you cannot chelate it, so you want to block the host cell receptors that the spike can bind to. Everybody just thinks about ACE2, but as you know from our work, we are covering now 22 different host cell receptors where the spike can dock to the cell and get in. These have to be closed before we even start. So here you see our products have been investigated in that context for some of these AXL and DPP4 and NRP1, all these receptors, and they work very well in many studies, and not only this one. So we are very positive now that we cover everything also apart from ACE2. Plus you have to bring down furin, TMPRSS2, and trypsin, which are fusion enzymes that enable the spike to enter into the cell. This we do as well. So we're making sure by all means possible. It's like, you remember, Pamplona, where the raging bulls run through the city. So everything is closed off. They can only follow a certain route, and that's out of the city.
One of the questions I'm thinking about is that I remember when I looked at the PET scans and I saw the changes in the heart in about maybe 20 to 30% of people. And one of the questions is, how do you know who is affected and how much they are affected without clear measurements?
Does it matter?
Well, I mean, in a sense, every intervention, what you don't want to do, every intervention I think of, and I think this is the lesson we learned from the pandemic. The pandemic was saying that just do this to everybody, and I think there is always a balance to try and identify who is at risk, who is most likely to benefit, and when. And I was just reflecting on that as I was watching that. And I think that may come from measurements, maybe from even microclots. If you can see, you need some measurement.
Should I answer that?
Ask Robin. Ask Robin, and she will tell you one thing.
Yeah, go ahead, Robin.
Let me answer that. Yes. So we have been looking now for several months at the microthrombi testing in almost every patient coming through our door. We encourage them to get it, or we sponsor them to get it. And every presumed long COVID patient, every long COVID patient or long vax patient or patient that we suspect has spike injury, okay, or persistent virus that gets the test, on a scale of 0 to 4, their microthrombi come back as anywhere from a 3 out of 4 to 4 out of 4. Okay. And these are in patients that I didn't come to me thinking they even had long COVID. I identified, serious abnormalities in their blood work and in their biochemical markers, which we're seeing on a daily basis. The vast majority of the population, when you check these specific biomarkers, they're not normal anymore. And I was floored by how every person had such substantial microthrombi. The pictures were unbelievable. I called the research nurse because, there's only 3 doctors in the US that are trained by Rhesus Pretorius here. And the one physician that I'm working with, I spoke to his research nurse and asked if they had a control group. I mean, presumably, unfortunately, there's no true control group because everyone has either had the virus or had the vaccine. So her answer to me was, yeah, we have a control group, people like me and you who don't think we've tested them, and they're coming up as a 2 out of 4 to a 4 out of 4. So Philip, to answer your question, I'm about to go do mine. So I'll show you mine and I'll report it. I believe I have it, and I have not done a full detox. So I think on every level, and I agree with you. I agree, like an intervention is an intervention, but the problem is the populace has been exposed multiple times to the virus or the vaccine or one of the other at this point. You'd be hard to find not someone that's never, maybe less than 1% of the population, maybe. But that's the thing. I believe that there is a lag between what you see biochemically, and Dr. Chetty, you can chime in, and what you see clinically, right?
Yeah.
So our jobs to see what's happening at a biochemical level, right? And be proactive, right? And try to reverse these findings that we're seeing before we see it manifest clinically. That's what I stay up. That's what keeps me up all night. That's what keeps me up all night.
I think that's the point that I was trying to reflect on.
Yeah.
It's so much about clinical medicine is about identifying risk. You
Yeah.
identify risk. This is why
Yeah.
we measure the cholesterol, we measure people's urine PCR, identify those who are at risk for something happening, intervening early, try and block it from happening down the line. And so it's that thinking that made me wonder about, I don't know what your thoughts are, Shankara, that, okay, this looks very promising. Is there a way that we identify those? Because is one the same as 4? Does one necessarily need treatment? If you see what I mean. And
Yeah.
it's trying to understand those nuances that I think is very important.
Yeah, I think, Philip, we need, like you said, we need specific tests to quantify what we're looking for in different patients, because we're going to see a diversity of things. In my practice, I see a lot of patients coming in with vaccine injuries, but they've been through many cardiologists, many loads of blood work, and come to me saying everything came out clear. There was nothing that they found. But I guess you got to know where to look.
Right.
If you're looking for something. And on these patients, invariably, like from COVID, I will do their C-reactive proteins, their interleukin-6 levels, their D-dimers, and invariably all three come out slightly elevated. Not as elevated as in the acute phase of COVID, but elevated nonetheless. And then with the live blood analysis, we've seen that there was strange clotting issues from the stacking in live blood of vaccinated patients. But now we're seeing that across the board. Even unvaxxed patients are presenting with those strange blood pictures. So I think each one is going to be unique in the way that they present. And I think as well, we need an understanding of our immune response to spike, because you might have a patient with a very acute immune response with high values, and the body eventually has to find a way to tolerate this. So the CRPs, interleukins, and D-dimers will drop, but not return to normal. And so these are slight nuances that we need to pick up on if we're going to find a diagnosis and effective treatment.
What I'm going to do here now is, I know Joachim hasn't finished all of his section, but I because we're talking about some of that clinical stuff, I want to jump straight into a part with Robin to just explain some of that clinical thing, and then we'll come back to Joachim here. When you looked at these biomarkers here, are all of them necessary, or is there anything that is absolutely critical?
That's what we're still trying to tease out, right? We know that 2/3 or more of the population that have this problem have, reactivated EBV. I see in a vast majority of my patients leukopenia, low white blood cell count. Not everyone has an elevated histamine. Some people do. The A beta 42/40 ratio is alarmingly low in many patients.
And could you just clarify what that is?
Yeah, so that basically is a marker before COVID. Neurologists would even use, or a lot of functional integrative doctors, like for older patients, especially when they're worried about dementia or neurodegenerative disease. It's a measure, it's basically looking at the beta amyloid production, which is, the problem, obviously, that neurotoxic fibril is what accumulates in the brain of Alzheimer's patients. So the ratio, shouldn't be below a certain level, obviously, or the number. And we were seeing this come back abnormally low in many people, even people that we just started testing it because we saw that it was, in patients with brain fog and some of the neuro-COVID, it was just coming back abnormal in many people. So then we decided to start looking at it in many of our patients, again, just to be proactive, to see if they have this issue already. Because like I said, I think there's a biochemical and clinical, there's a lag between what's happening biochemically and clinically. So we use that marker a lot. And we've also used it to help us with our different iterations of the protocols to, give us, real-time clinical feedback on if these are working, if we're perhaps causing these fibrils, to be exposed, based on how the spike protein is being liberated, and so on and so forth. So a lot of these we've been using. The TGF-beta 1/2 it's markedly elevated in everyone. I mean, almost everyone. I would say 90% of the population, post-COVID exposure or post-vax exposure. Prior to the pandemic too, maybe we'd only see it elevated in patients with mycotoxicity. It wasn't really something we would see abnormal on most patients. So we're still, as a group, as a global research collaborative group, trying to figure out the specific biomarkers, and we think we're onto something, we can talk about that down the road, but we think we've figured out a panel that we can look at before and after in patients to really, look at their progress, especially when we put them through this, spike detox protocol.
Can you just take us through what you're looking at with regards to microclots here?
Yeah. So if you look at the one on the left-hand side, that actually is a grade 4 out of 4.
So this one here.
Yeah, the one on the left where you see like the big green globules. After this patient went through one of the iterations of the spike detox protocol, they cut it in half pretty much, as you can see on the right. So we're in the midst of getting back more and more of these, and we'll probably, we will write this up, likely as a clinical case series, so we can present our results. But this is promising because I think you guys agree that triple anticoagulation therapy has its own problems and issues, can be quite dangerous for a lot of patients. And this is using natural compounds that, as Joachim outlined, that can be, super important for removing the spike. Therefore, you're calming down the endotheliitis, therefore, preventing this, ongoing activation of the coagulation cascade. So hopefully, this could be a natural means of combating this and getting rid of these microclots.
Okay, so here's a question, as a, again, research clinical question.
Sure.
Is managing microclots the same as trying to reduce glucose in diabetes and not dealing with the insulin problem?
So I believe that the problem is the spike protein. So if you remove the spike protein, the endotheliitis should get better and the microthrombi should then regress or go away.
So again, one of the things that I've been looking at from a research point of view, my question is where in the world is this spike protein resident to still be being produced 2 years down the line? And as far as I could see from the research point of view, it only pointed to immune cells. And immune cells, then, how do you switch them off? And this is the big question that tied me to some of Shankara's strategies, where he uses steroids, because he's trying to reboot the system, switch off the immune system, hopefully let these cells die and switch them back on. Because we need to get rid of the source of the spike protein. It's one thing is to mobilize. We can manage it, but how do we deal with the location wherever it is in the body? Any thoughts, Joachim?
Yeah, look, we spent this, I don't know how many thousands of hours now on this whole thing. So, okay, any cell that harbors or produces a spike protein or coronavirus by itself will automatically switch into the senescent state. And by doing that, it will secrete the SASP cytokines. And by doing that, it will mobilize our senolytics. It's like a surface-to-air missile station sending out a radar signal, and you fly by with a fighter jet, and you know exactly now, okay, my friend, now I got you. Huh? And bang, and that's it. So even a cell that would be transfected or with a lipid nanoparticle with mRNA and still produce spike after a long time after vaccination would express the same SASP cytokine signature. And that makes it prone for our attack. In the immune cells, there's also, it's called a immunosenescence. It's the same ballgame. And so I think that we can target all these cells with the same kind of approach. Just as I said before, we have other problems that we are chewing on. Our problem is, for example, if you break up these cells, I mean, you have to break them up anyhow. But if the progenitor cells and the stem cells are also compromised, as we have seen in the skull bone marrow, you have spike protein in there and virus. So the stem cells themselves are compromised. So you will lack the replenishment of the cells to replace the cells that you were taking out in the first place. That is where we're chewing now, and how to get maybe mature cells into pluripotent stem cells and these kind of things. So we're chewing already 20 miles ahead on the problems that might occur later. But that we are not confident now to break these cells up. I will fly to Carlo, and we will take his patients that are presenting spike after 6 months after vaccination, and we run them through the protocol. And then I can give a report maybe in 2 or 3 months, how well that worked. Now, so we are doing everything now to take this out at the root cause, because if you don't take out the spike, nobody will ever get healthy.
All right. So let's just take at some real patient things, Robin. Just tell us about this situation here. What's this?
So this was, these were just few case studies that we highlighted. This was a 66-year-old long COVID patient, chronic fatigue, post-exertional exercise malaise, dysautonomia, POTS-like features, and, really bad brain fog. And then if you go to the next slide. So I just highlighted some of the biomarkers that were abnormal. As you can see, at a very high TGF-beta1. We do look at the SARS-CoV-2 antibodies. That's a whole other discussion we can get into, but we like to follow that to see if, as we move them through the protocol, if those are actually moving down. Many of these people, especially everyone we're seeing now, their antibodies are off the chart elevated. So it just, because we think that the person, because they have ongoing spike exposure to whatever degree, their body's just continually making these antibodies. As you can see, he has a very low A beta 4240. It was 0.126. Normal range is around 0.170 to 0.180, depending on the age. And again, positive ANA, vast majority of our patients, I don't know if Dr. Chetty can say the same thing, have low positive ANAs because of autoantibodies likely. And he had his EBV was elevated. You can go to the next slide. These were the earlier iterations. This was really before we were using even the more comprehensive protocols that we've come up with, but just by using the Vedicinals alone in combination with the Rhizo Health and transresveratrol, a little bit of the senolytic there, fisetin, with DC, zinc. This is what happened with him. If you go to the next slide. His TGF-beta1 went down to within normal limits, like below 2200s normal. His VEGF, which was high, actually just went down to within normal range. His SARS-CoV-2 started to trend down. His A beta 4240 went totally back to normal. 0.170 in his age group was normal. His ANA went negative as well, and his EBV went undetectable.
At what kind of time frames are we talking about here?
This gentleman, probably after about 6 to 8 weeks of therapy.
Yeah. And if you take that patient, say 2 months later beyond the therapy, Are they
Yeah.
still stable, or do you see any kind of rebound with
Yeah,
them?
so this is interesting. So some of the patients from the earlier iterations, I've had to retreat them with the newer iterations because there was probably more spike that we never got to. Once we treated them with the newest one that Joachim was really going through, they've been good for like, a few months out so far. That's why I believe in general, and Dr. Chetty, I'd love to hear your thoughts on this too. Like all these patients in the beginning that we were using, whether it's like a combination of like ivermectin, steroids, this, that, and plus all the natural compounds, like you get a lot of patients better. They really feel better. And then all of a sudden, like a few months down the line, several months, they're awful again. And it's because we didn't rip it out by the root being that the spike was never really addressed, right? We weren't really, maybe some of this was working on the spike and releasing it in some way, but it was never really truly being addressed. And that's why all of these patients had all this, ebb and flow, and then just keep getting worse and worse and worse. So I think that's what we've come to discover at this point, and that's why this is so urgent and needed for so many people.
Thoughts, Shankara?
Yeah, I think Robin's completely correct. I've seen it in my practice, Philip, be it long COVID or long vax issues. There are people that show good recovery with initiating treatment. And of course, my treatment allopathically is addressing the cytokine release and trying to calm the inflammation down. And by doing that, you see good clinical improvement in a short space of time. And then I try and taper. But the tapering is because I'm very conscious of rebound. And with a lot of patients, I'll put them on medications to control the cytokine release for periods of 3 to 6 months, and they do well in that time. But as soon as you take the meds away, there's the subset of patients that want to rebound. So it's vitally important that we get the spike protein out. You're sitting with something either toxic or allergenic that is resident in the body. You're never going to solve a peanut allergy if you don't get the guy to spit the peanut out.
Robin, I want a question that I'm interested in your thoughts on.
Yeah.
Do you find, or do you think that some of these patterns will occur in everybody, or are there a subset of people who have a predisposition for developing these kinds of conditions?
So I do believe that there's not just a small, like a large subset of people that are prone to developing these set of conditions for sure. But unfortunately, I feel like I'm seeing more and more and more in the general population a major problem here because it's only like you can only escape it for so long, right? I mean, now we have patients being infected with COVID 3 or 4 times a year. They're getting infected. They're turning positive multiple times a year, or they've had the vaccine 4, 5, 6 times, right? So it's to me, it's becoming a generalized problem, through most of the population.
And so a question here for Joachim is that we have JN1, we're going to end up with JN2, 3, 4, 5, 6. And you're quite right. If you have multiple reinfections, what needs to happen is that you need to stop the source of spike from wherever it comes. Are any of these products able to block infection as well as mobilize spike?
You know that when we set out in early 2020, that was our goal to start with. That's what Vedicinals is built upon. And we have added now these nice late nasal sprays that are covering the nose with the same compounds, because I think that 90% of the infections go through the nose. And so it's a valid approach to go after the virus in the nose, also in a prophylactic manner. But maybe I can say something as a final thought to this discussion. I don't know how much time we have. But in my opinion now, me and Robin, we are looking at the patients now before and after the detox. We are that far already. Now that we are discussing what are we going to do now, I talked to some therapists yesterday in a webinar, and they were wanting to do this, and then we go for the mitochondria, and we take that care of the inflammation, and we do that. I said, look, guys, whenever we finish with the detox, you go ahead full stream, but let us first detox, and then we can start really helping these patients. But until that is out, and you have to protect yourself. Yes, of course. How can we do the best? Is it take some prophylactic, whatever, if the Vedicinals or other products that are proven to help, and nasal sprays, and maybe just avoid maybe the too big crowds in very stale air rooms and things like that. And because and one more thing I want to say in the context of autoimmunity, because I know that you have been on that since the beginning. And Robin, correct me if I'm wrong. If you don't take care of the spike and you wait too long, then of course we can see that the body will start to attack the the cells presenting spike on the membrane or viral debris on the membrane or in the cell with autoantibodies. And that is what we see now in the very, very severe long haulers from actually the first wave from 2020. They are really suffering now. And that we shouldn't wait with the other population to get into that stage, because then I don't know what we can do. Then maybe apheresis can still help to some part, but then we're at the end of using nutraceuticals and dietary supplements, I can tell you.
You know, Shankar, I was thinking about what Gert had said with regards to the change in the immune system, where the body is no longer trying to fight this with antibodies and primarily going after the virus just with the T cells, and which is the final stage, I guess, of the immune system. But what it's indicating is that a vast proportion of the population cannot control the viral infection. And what we may be seeing is persistent infection. This is why I asked the question about stopping infection, because even if you clear the spike, when they get reinfected and they have viral circulation, we are back again to where we were. This is a beast of a situation that we're in.
Yeah,
Yeah,
there
I think
are
we're
there are
dealing.
other
Look,
angles.
yeah,
Sorry.
like I initially alluded to, if we're dealing with spike protein in the virus, and that's one exposure, and a long-term exposure. We're also dealing with spike protein being expressed by different gut bacteria. We've got the vaccines, and we got the issues of shedding that come with that. So spike protein should be thought of as a environmental toxin. It's in our
Yes.
environment, and we've got to figure a way to avoid it. It's all
Yes.
around us. I'm exposed to it every day. I have to think clinically, and with patient exposure to spike, it tends to trigger an immunologic response first up. And so I'm training patients to recognize that immunologic trigger early on, so we don't end up 6 months down the line with problems. So some patients will present with sudden onset arthritic pain. Suddenly one day they want to get off the couch, and they feel like they've aged. And that's an indication you've been exposed. And then we just do the standard thing to try and suppress that immune response and try and suppress the cytokines at that point. So I think, yeah, it's going to be an ongoing process. Different people are going to be injured in different ways. We're going to take time to see those injuries. When we detox as well, we're going to detox differently for patients with renal issues and liver issues. We're speaking to Joachim, we got to be cautious as well with using enzymes to break up the spike. We know the spike is made up of many different toxic epitopes, and it might only express the surface epitopes, and breaking it up exposes you to the total potential of its toxicity. So the binders become important. Are they binding spike in its completeness? Those
Yeah.
binders with spike, how are they eliminated from the body? Blocking receptors so that we don't solve one problem and create another in the rush, because the spike has high affinity for a lot of different things. So I think there's a lot of work, but I think we have a good basic understanding of where we need to go.
Yeah, you raise a point there, Shankar, that I think is one of the things that I'm noticing is the amount of kidney injury that we're starting to face, is that a lot of patients have ongoing kidney injury.
Yeah.
If, therefore, when we mobilize spike and we are binding it and we are dependent on the kidney to excrete it, is there any other route? Because the other routes are there's sweat potentially, there is the GI tract, There's and you're right, is that it almost needs to take into consideration where is that person in
And
terms of.
Philip, the kidney is also prone to being damaged by antigen antibody complexes. Gets plugged with them, gets damaged with them, and that's what we're dealing with. People that took the vaccine have high antibody levels, but circulating spike, and those are going to complex together, and we're going to have to find a way to get rid of them.
Philip, now you have to go back into the presentation now.
Yeah,
There's a
yeah, yeah.
slide on the kidney.
Tell me which slide.
I don't remember it out of my head. Just go somewhere in the end of my
I
presentation.
think I know where it is. I think I know where it is. I think that let's run through some of these here. I think this was where
Yeah.
we were.
Yeah. That you can skip out that. Let's not take up too much time. Okay, this is interesting now. As Shankara has mentioned, we do have a lot of virus in the gut. And so we have a product that is a very particular humic acid here from Germany that is proven to chelate. Actually, we did it for glyphosate, but now it comes out that a pure humic acid can also chelate the spike protein and the whole virus. And if you go down the next slide, then you understand why that is really important. Remember Carl Lebronia? So we have all the bacteria in the gut full of virins, and now I think also spike protein from the vaccine that is under investigation. And so when you take out these bacteria by whatever means, antibiotics or whatever, you will release all these virins, and then they will go to the epithelial layer, and the spike and the virus will then settle there and make more problems. So even in the gut, so we are in the detox, we are distinguishing between the brain, the rest of the organism, and the gut itself. Yeah, so these are the three distinct regions where we need to have all compounds at adequate amounts at the right time and place in order to make this functioning well. But you were talking about the kidney. I don't know if it's coming behind that or before that. No, that's still gut. We can skip that. Yes. Okay, here we go. So we are all worried about the kidney. So some people went, and thank you for that, went at looking at quercetin in the context of SARS-CoV-2 pathology, especially on syncytia formation and entry into kidney cells. And if you look at the next slide, you can see that quercetin was very, very good at it to stop any damage from passing spike protein through the kidney. I see it's like several times reduce the size of syncytia and the entry of spike protein into the kidney cells. And we are not only relying on quercetin alone. Yeah, we're making sure that we have pure quercetin in the blood at a high amount, because this here is an in vitro trial. So you want to make sure when you take these compounds that you have the pure amount of that in the bloodstream so that it can do the job that has been shown here. But other molecules will also be helpful there. Plus the chelators will block the spike from even starting to do this. Yeah, so your concern are right about the kidney, and Robin is doing especially a kidney restore and a gut restore. Robbie, why don't you explain that before we do the spike detox? You're going through a two-week protocol.
Yeah, during the first 2 weeks, and it's very interesting because a lot of the patients prior to this iteration too, like they notice a very big difference, especially people that have like very heavy gut symptoms. They feel much, much better. We bring them through more of this like gut detox where we're really addressing any spike protein or virus that is likely in the gut with the binders and other things that are restoring health and balance to the gut microbiome and the intestinal mucosal barrier. And we also give them at the same time 2 natural, supplements that address the liver, GI detox pathways and the kidneys as well, to sort of like open up those pathways so that, they can really detox from these things a lot better, because many of these people's detox pathways are clamped down anyway. And so by giving them, this support, it's helping them, I think, mobilize and move this out of them more easily and safely as well. We've been having good results with it.
Okay, quick question here, because you could imagine some people who look at the discussions about nutraceuticals and they look down on the fact that you're not using a drug, you're not using a tablet that has. How do you answer those criticisms?
Yeah, so I'm a conventionally trained doctor, and I use prescription medication when appropriate. The problem is you're talking about a beast of a disease that's affecting over 300 different biochemical pathways, okay? So when you talk about pharmaceuticals, you're talking about drug targeted pathways. Like most drugs only target one pathway at a time, right? So you have to infuse into the body compounds that our body knows how to use that can work on a multitude of pathways simultaneously, right? Obviously, it has to be at the right bioavailability, so on and so forth. But that's why Joachim and the research group have gone to, very, very great lengths to study these molecules, both, in vitro and animal trials and also clinical trials as well, to show how efficacious they are. I'd be prescribing my patients like 50 to 100 pharmaceuticals if that's what we're talking about. It will be impossible to treat patients this way. So we have to think outside of the box, and we have to think about, like, from an evolutionary standpoint, what do our bodies know how to use, right? All of these natural compounds, and they have thousands of studies, hundreds of studies on every single one of these compounds and how they're utilizing these pathways and how they, block different receptors and all these other things. I mean, this is not like voodoo medicine. This is very well studied. There's probably many more studies on these compounds than any pharmaceutical compound that's been created in the last several decades. So that's my answer.
I mean, I think that it's interesting that just recently the retired step-down editor of the New England Journal of Medicine is highlighting how many studies clearly are not actually true studies, and how much the medical industry is influenced by the pharmaceutical industry, technically, to become a marketing arm. And when you have products that are more easily available, you still have it looked down upon because it hasn't got that idea that it's a drug and it's been through a big trial. So there's a lot of education that needs to occur in the population to make them realize that the two are not necessarily separate. You can still use nutraceuticals as long as you know what you're doing, when you're doing it, and what medication that they're on. Now, I think we're going to have to wrap up now, guys. This is a fascinating discussion. I know we could probably go on and on it, but I'd like you all to put in some final thoughts. I'll ask Joachim to start first, then Shankara, then Robin, and then we'll close out.
Yes, from my side, I want to make it short. It is, for me, the big hope that more people understand what people like us are doing, and that, let's say, conventional medical doctors will also start to respect that this is a really well-working and successful way to treat, especially these multisystemic diseases. And it seems to be happening right now. So I'm very happy and confident that we will succeed now to help a very large amount of people. Thank you for today's stream.
Wonderful. And Shankara?
I think, Philip, there's hope. I see my patients recover. We know where we're looking with the gut microbiome, with all the different things that are coming to the picture. And it's actually forced us, COVID did a good thing in forcing us to integrate our holistic approaches to medicine, not just be allopathic. And from the start, I realized that the pathways that this spike protein damages is too broad for any targeted pharmaceutical intervention to treat. And so we had to go down this road of nutraceuticals. And with Joachim's work, I think it's vitally important. The only issue I'm dealing with are these rebounds. And so with detoxing, we'll be able to stem that. And I think we've got a bigger environmental problem on our hands. And I think that's going to be left to government to actually figure a way around this. Not keep exposing us to spike in the future.
And Robin?
Yeah, I echo a lot of what Dr. Chetty just said. Unfortunately, the vast majority of the healthcare community doesn't understand this disease. This is, again, like Joachim said, like hundreds of thousands of hours of work, night, day, breathing, eating, sleeping with this. And so, there is hope. We poured our hearts into this, and there are treatments, and we do see patients improving and getting better. And like Dr. Chetty just said, unfortunately, we do have this ongoing exposure. So as we learn more about the pathophysiological drivers and can figure out ways, from a preventative standpoint and things like that, I think, we'll basically be able to climb our way out of this. But I think that there is a lot of hope, and people should know that where doctors like myself, Dr. Chetty, and scientists like Joachim, and also obviously like you, Dr. McMillan, we're out there and we're here to help. And, we've been having really good success with these patients.
Excellent. Thank you all very much. This, as usual, was educational. Lots of stuff that we can chew on, and critically pointing us to the future where there are routes that can be developed to bring health back to the population. There's still a lot of work to be done. And believe me, the pandemic, or the impact of the pandemic, is only just starting. And we still have to find solutions for patients across the world. Thank you all very much. I'd like you to stay with me until after the outro. But for everyone else, I look forward to having more presentations with you all. Have a great evening.
Thank you.
Bye-bye.
Bye.
Thank you.